Bismillah ar-Rahman ar-Rahim. I would like to thank our brothers from Emirate, Dr. Abdullah Shahab, also all the GIS Society Scientific Committee, دكتور موسى أكبر ودكتور فواز المطيري لحسن الضيافة والاستقبال والعرض الرائع لانضمام العراق إلى جمعية القلب الخليجية بين إخوانهم وممنونين لكم كثيرا. Actually, it is not so difficult case, and it is a simple case, but it has a lesson for learning. That's why we present such a cases, although it is simple, but for the learning and how to avoid such complication, which is easily avoidable. So this is the patient. He's 55 years old, male with history of type 2 diabetes, smoking, and dyslipidemia, presented with ongoing chest pain following a previous ST elevation myocardial infarction, anterior myocardial infarction, and he was treated successfully on medical treatment, but he suffered from the post-anterior MI angina. Later on, the presentation of the patient that he is having ongoing chest pain. That's why angiography done for this patient. You can see and you can appreciate that the right coronary artery also has been involved. You can see the critical lesion in the mid of the RCA. It is a little bit tight lesion. And that was our culprit. We think that the pain or the chest pain post-anterior STEMI is from this critical bifurcational LID lesion. So simply, we go to the LID and 2-wire, one in the main branch and to the diagonal, and with a kiss, keep it simple as much as possible. There is no need provisional stenting of the mid LID. Everything was going good, and this is the final result of the LID. Is a little bit accepted. Shifting to the RCA, because it was also critical lesion. And the patient, the other thing is that the patient in a private center, we don't need to bring the patient again to do another procedure and more costly. So after shifting the patient to the right coronary intervention, what happened? After we are missing some picture. After crossing the lesion with a little bit stiff wire, that's what was happened, and the patient developed acute inferior myocardial infarction on the table with shock, hemodynamic instability, and severe chest pain, tightness, and so on. So what do you think at this stage, what happened?
Where's the wire?
It should be.
Okay. Yeah, there's wires out, no? Wires out? Agree? Yeah, okay. يمكن picture مو موجود بس wires out.
ايوه للاسف لا كانت موجوده بالعرض هسه الشباب خلاها.
الصورة الثانية شغلة؟
This is
لا ما في واير. There's no
لا
wire.
قبلها هذه.
بس يمكن الصور مش موجودة.
سوالها ديليت هسه بالابلودينج. So
Okay.
abrupt visual closure.
Without wire.
Yes, during initial session of the RCA intervention causing acute inferior ST elevation myocardial infarction, and the patient, as I mentioned, developed such complication. So how we can pass this situation? The first thing, don't be so worried. We try to be a patient with the patient, careful resuscitation. We bring other wire and cross the lesion. The previous one was a CrossFit 100. Oh, this is the. You can see.
second attempt, صح؟
Yes,
ولا؟
yes.
Okay. So what wire we use here? Do you know?
I think Pilot 50.
Okay.
Pilot 50, the second wire, that was the ST elevation.
Anyone use different wire?
Yeah, why the stiff wire?
Why? That's why. This is my question. I think that was after finishing the LID, the assistant said, give me any wire available. He gave him a CrossFit wire 100. I don't know that. I think it is a simple lesion. It is soft wire like that.
But
yes.
what was the LED wire?
LID wire, BMW.
Why you didn't just
Change, yes. That's what happened. I will transmit the thing which happened. So give me any wire give me any wire available by and that was the problem.
So the pilot wire, yes.
Yes.
Then what happened?
We cross the lesion, yes, and we avoid the false lumen, and this is the final result of the patient, and control angio after that, and the ST elevation settled, and this is after 1 year. The message from this case is that never attempt pre-dilatation unless you are sure where are you. Stiff wire, as our colleagues say, is not recommended in such an easy lesion and simple. In multivisual intervention approach, there is safety concern to be so safe, and in acute coronary syndrome, PCI rationally sound to perform it firstly and to the culprit lesion, but certain criteria put the patient or the management of such patient in individualized manner. One of them is a challenging that we are in a private center. The most important factor that guide treatment in abrupt visual closure are the patient hemodynamic stability and how rapidity in stenting and treating and keeping the wire, and you choose another wire. And this is the last picture. Abdullah Shab not appearing in this picture from GIS. And these also, Dr. Ahmed appearing. Yes. And those are ziggurat of Arab. All are ziggurat of Arab. And this is ziggurat of Ur in Nasiriyah. And thank you so much.
Excellent.